Well, and it's funny. I know a lot of IT professionals in healthcare, a lot of IT professionals in general would probably disagree with this, or I know some disagree with it. It's always seemed to me that APIs aren't the solution for everything, and so um, I know an awful lot of IT people who want to solve everything with an API, but it's not feasible in some cases to do that. You may have restrictions. I mean, we all know that with the electronic health record systems, it can be very challenging to connect into their systems with a piece of code. And we had turned people into human APIs, right? Their entire
That's
purpose was
exactly that's
moving
exactly
that
true.
information back and
Moving
forth.
data from one place to another.
Yeah.
And
So
I mean, I will be the first to say I love the API connectivity, and where it's appropriate, like you said, the digital workers handle that very well, very very easily. Blue Prism is a no code platform, and we really emphasize that. So we prefer not to do any coding. We now have API built into the digital workers. So really, essentially, you only have to give it the connect points and whatever it's going to need to get an acknowledgement back from that. So there, we have appropriated that into the platform itself. So it's really easy to create APIs, but that's still not always the answer. What's at the other end of the API? Is the other service center ready to accept an electronic path, or are you still going to run into stumbling blocks and roadblocks? So there's other times that you have to have the digital worker execute a human task,
mhm.
and that's what they do best. So I agree with that point of view. I do love that ability to do that. But I think you and I talked about this, but even in Epic or in Cerner, McKesson, Meditech. Meditech is a fun one. Yeah, that one's fun. But even in some of those systems where they have made restitutions to their software to accompany an API path and connect to the payer organizations and try to make it a smooth transition, without the education that goes on at the front end for the people who are operating those systems, they may not know that even exists. In many cases, it's as much or as simple as clicking a button when you're registering a patient, which we can turn that over to the digital workers now. You don't have to sit there and register your patients. But as a human task, if you're registering a patient, there are certain buttons that you got to know to select before it's going to turn on the SMS messaging, before it's going to turn on the my chart updates. A lot of things that they say are automatic in the software now do not necessarily transcend to automatic.
Right.
So if you have a digital worker that is in the case of patient engagement, we talk about the trail of information from the time that a person requests an appointment to the time that they actually encounter the physician in the patient journey. There's a whole list of steps that have to be done and completed and are not always executed, in the human world according to plan. So taking that process and automating it allows those kind of things to happen. If you have that overlay available, then it doesn't matter whether the system has that built into it or not, because that already checks and does a checks and balance. Okay, does this person, using machine learning, they can watch, does this person know what is appropriate in there? Or, by creating their first register or two, then it can pick up on it. Okay. Mm-hmm. Or if not, then we just blanket the whole thing. The digital worker will just go ahead and execute the entire thing without having to use human in the loop or justify whether or not it, so it enhances the learning as well, I think. Because training has been an issue. There's a huge turnover ratio in clinical support. Yeah. Clinical administrative. And many, many times, and I've seen this happen so many times, you get somebody in there that's really good at being administrative support in a clinical operation, and they get so excited about the medical profession that they go back to school, they learn something else, they become an MA, they're no longer actually a part of the administrative process, they're not sitting there at the desk. Or it could be someone who is in college already studying to become a doctor, but they will choose to sit there and do the patient registration piece so that they're familiar with that piece. But then they move on. So then it's turnover. Somebody else has to come in. Do they get the same training? So with at least this adds consistency. having a digital worker execute that, know the steps that they have to execute, dependent upon which system that they are, and being system agnostic, um, allows us to fill in those gaps and make it an either or both type scenario.
Well, and certainly right now, as we're, as at the time of the recording that we're doing today, we're, you know, COVID vaccinations have ramped up. There's the beginning of some recovery, but we certainly know that in 2020, the healthcare systems, many of them took a pretty significant financial hit. And one of the things that they did to adjust to some of that were often staff reductions on the administrative side. If you're going to reduce staff, you're not going to reduce your clinical staff. That's
Right,
what you're
right.
there for. So you're going to reduce administrative staff. And so it seems to be now coming out of this, there's beginning to be another peak of interest in how, not necessarily to not bring those administrative people back, but how do we mitigate the type of scenario that we've just had. And you mentioned CMS, the Center for Medicare and Medicaid Services. For those who may not know, there's a lot of work being done now, a lot of requirements proposed and final rules being set out to try to increase some of the digital transmission of information, trying to break down some of those interoperability barriers. But there's always going to be a place for the type of personal interaction, and that's where I think what we've been working on at Sykes Digital and Blue Prism over the last few months as a part of your Digital Health for the Enterprise program is really changing some of the dynamic from where RPA specifically has been before in healthcare. I started my practice in the back office. Most people started their practices in the back office. Depending on how you view revenue cycle, you've maybe had some action in the middle office, but that patient-facing activity has not been something that has been a primary focus specifically for RPA over the last many years. And so let's talk a little bit about making that shift and getting healthcare practitioners to start thinking about it as more than just I can have it scan remittance advices and update remittance advices
Yeah.
and that type of stuff in the back office. We're now actually talking a lot more about
Yeah.
interfacing with the patient.
And I think that COVID has played an instrumental part in opening up that window or that door to a virtual world, because we now sit in our own cocoons, and a lot of our appointments were held by telemedical docs. They've become more comfortable with doing that. I was just speaking with a physician this weekend, and she was talking about how she even does consultations from psychiatric evaluations now through virtual. And I said,
Mm-hmm.
that's such a people-oriented one-on-one type thing. And she said, well, I've learned techniques of whenever they're talking to me, how to lean in, and talk to
Right.
them and things like that. So we've become more comfortable in that. And I'm hearing from the physicians, we're perfectly fine where it doesn't have to be a one-on-one. If the patient doesn't feel comfortable, if they're having astigmatism or a stigma, well, anyway, if they're averse, you can cut that part out.
Sure.
If they're averse to actually having that one-on-one interaction, then they can start to trim back just a little bit and say, okay, we accept the telemedicine, we accept telehealth, but some of the doctors are saying, let's take it a step further. And we said, you know what? Digital workers can do that. The digital workers can do everything from search engine optimization all the way through to managing the referrals, all in the front office. Now, how many times have you engaged, with a practice and the biller is sitting back there and they know nothing about that patient until they get the bill on their desk?
Yeah.
And they're like, why did we not get a pre-auth on this? Why did we not get a referral on this? Can somebody get me a referral? Can you? And then they'll call on one of the other girls in the office. Can you call and get a referral on this? I've got the bill sitting here in front of me. I can't mitigate payment. So many times that's the case. By putting all of those steps into a virtual path and assuming that nothing is going to transact between doctor and patient until all of that stuff has already come through a path. The digital workers requested the referral. The digital workers requested a pre-auth if required by looking at the CPT code that the doctor hands out. Um, those different steps, it takes all that burden off of the back office on that little biller that's sitting there trying to make sure that all those are keyed properly. It is taking advantage of some of the steps that we've put into the EMRs already, to help with the SOAP notes, with the repeat visits and those kind of things for the physicians. But at the same time, it moves all of that stuff back from the back office out to the virtual window, is what we call it, the virtual door.